Hello, everyone. Welcome to the webinar. I'm Dr. Hal Danzer, one of the co-founders of Southern California Reproductive Center. And this month is Endometriosis Awareness Month. And we picked a topic to talk about the medical part of endometriosis. But we have Dr. Carissa Gustafson, who is kind of a subspecialist in the treatment of patients with chronic pain syndrome associated with endometriosis. And we'll talk a little bit about how endometriosis can impact one's fertility, how it's diagnosed or how it's difficult to diagnose actually, and some of the treatments that are available. You see that my grandmother in rural Montana in the late 1800s, 1900s, was a midwife. And I always kind of wonder what her treatment package was for patients that had fertility issues, because there weren't any really physicians in that part of the country at that time. And, women took care of other women as a midwife, but they also probably took care of most of their gynecologic problems. So it's a little bit in the genetics. Everybody who asks, how did you get to be a reproductive specialist? And there are other things along the way, my interest in endocrinology that motivated a lot of it. But just like endometriosis, which is genetic, the predisposition to that is there. We know it runs in families. And of course, almost everything about us is determined to some degree in terms of predispositions, how we have certain good factors and medical issues in our life. So I'm going to turn over to Carissa, and we can start with the presentation.
Hi, everyone. My name is Dr. Carissa Gustafson, and I'm a licensed clinical psychologist who, as Dr. Danzer shared, specializes in perinatal mental health, including infertility, or working with individuals and couples that are undergoing reproductive challenges. I see clients as a part of Village Birth in person at Pasadena, as well as online throughout the state of California. And I'm excited to be here today and talk with you more about the relationship between endometriosis and mental health. Next.
So that came back to me. Talks a little bit about Southern California Reproductive Center, and we have 3 locations. Our primary office is in Beverly Hills. We've been here 25 years, where we have a kind of state-of-the-art laboratory. We're noted for our ability to create embryos at a very strong rate to what they call blastocyst stage. We employ what they call an embryoscope that allows embryos to be imaged many times during the day, and to look at how they grow and the characteristics of the early embryo that tells us some about their potential and how to rank embryos in terms of transfer. So we've always had our eye on the horizon in terms of the latest developments in technology for our laboratory, and that's really translated into some of the very highest pregnancy rates in the Southern California area. We have 5 doctors now, and next slide. So we talked about our laboratory, and again, the thing that drives the quality of the laboratory, we have a PhD that is full-time or part-time. We have a crew of about 12 embryologists, and again, that allows us to double verify everything that we do. If we're going to freeze or thaw an embryo or egg, it's one embryologist does that. There's no handoffs, but there's a second embryologist that allows to double check every step along the way, so that we're not made, there's no man-made mistakes in terms of transferring the wrong embryos. We've been extremely lucky in that area. Next slide. Again, we'll talk about endometriosis and navigating the mental health issues, and some insights and resources, and then some testing. We'll talk about that. That's some of the research that's going on looking for a marker for endometriosis they might be able to detect in a blood test, and then treatment options. Next slide. So here we are, Endometriosis Awareness Month, and it's important. It's estimated that perhaps 25% of women have endometriosis. For many, it's what they call silent, where they don't have much of the way of symptoms of pain, but it can affect their fertility, and we'll talk about that a little bit later. Next slide. So endometriosis is essentially normal tissue, which is in the lining of the uterus. The lining of the uterus builds from about 4 millimeters up to 10 millimeters at the time of ovulation. And then the lining breaks down at the time of the period. But that is what they call utopic tissue. It's in the right place. It's the lining of the uterus and nowhere else. However, endometriosis can occur in the wall of the uterus and occur on the outside surface, the tubes and ovaries. And again, when that tissue is not in the proper place, it creates probably an inflammatory process. There's a lot of studies showing that cystokines and other substances are abnormally high in women with endometriosis, particularly those that have fertility issues. There's been a long discussion to say, well, how does the normal tissue inside the uterus get to the outside? Does it travel through the blood? Is it a sort of a mutation of the tissue in the pelvis? And that's the source of a lot of controversy even today. Next slide. So we talked about endometriosis affects approximately 10 to 15% of reproductive age women. Some say 25%. There are some studies that argue that perhaps 50% of fertility patients have endometriosis. Again, the undergoing diagnosis can be a very difficult endeavor. Certainly the history of more painful periods that evolve over the period of several months to several years is the sort of the warning that endometriosis is no longer silent, but is progressing. But it develops over time, many months to even years. And a lot of women go undiagnosed because it's one of those creeping effects that they don't realize how much things have changed as opposed to 2 years before. And so it gets overlooked in terms of general gynecologic examinations because there's no good way to find small amounts of endometriosis. It does not show up on ultrasound most of the time unless there's cyst on the ovary, and that's not a frequent finding. There's been some new studies looking at MRIs to look at deep endometriosis. But again, we don't have a blood test that you can do, for diabetes or high blood pressure. There's blood tests or markers. We do not have that for endometriosis at the present time. And then if you look at that bottom sentence, 30 to 50% of endometriosis in infertility patients. And again, difficult to diagnose. Luckily, many women with small amounts of endo seem to get pregnant pretty easily with IVF or other treatments, but there is a subgroup that just struggle. And again, it's difficult to diagnose that subgroup. So next slide. And how common the symptoms, painful periods, pain with intercourse, because the inflammatory process may thicken some of the supports and the tissue that surrounds the pelvic cavity. If it's on the bowel, it could cause problems with urination or bowel movements, heavy bleeding, excessive spotting before and after the period. Sort of develops gradually for some women, and then they look back and say, gee, this started several months or years ago, and I just didn't pay a lot of attention to it. Other problems, diarrhea and so on, can affect the bowel. And then fatigue and low energy, how much is that from the actual process, or how much is it just the fatigue from dealing with the pain? And that is real. Next slide. So laparoscopy was the standard way of diagnosing endometriosis. You look at it with a telescope, goes through the belly button under general anesthesia. And that was a part of the standard treatment for infertility in the past. It really has not been often used unless the patient has a lot of symptoms or there's findings on ultrasound showing that there's cysts on the ovary. what they call endometriomas. And then it can be treated with laser or stripping out tissue that's affected with endometriosis. But there's multiple studies that show that if endometriosis is treated, it does enhance fertility. It talks about the multiple proteins that have been studied as potential surrogate markers for endometriosis, but we just don't have a good blood test. So that is some of the problem with diagnosis of women that progress from silent endometriosis, small amounts, to large amounts of endometriosis. But we also know that the position of the endometriosis is a factor too. Endometriosis cysts on the ovary may not cause any pain at all, but implants on the ligaments that sort of feed the nerves, or the nervous innervation of the uterus, can cause severe pain, or pain during intercourse, or bowel movements, and so on. Aside from surgery, endometriosis can be treated hormonally. And Depolupron is one that we commonly use today, or birth control pills, both lower estrogen. And again, estrogen is what develops endometriosis tissues and stimulates its growth. So the findings of endometriosis pain at ovulation, when the estrogen is the highest, or just before the period when the lining of the uterus is breaking down, these little endometriosis implants also break down and may cause pain. But by stopping ovulation with birth control pills, or suppressing it even more profoundly with Depolupron, it certainly can enhance fertility after those treatments. Next slide. So we talked about contraceptive pills and progestins and HSs. There's a variety of products that are there to essentially lower estrogen. Statins and CoQ10 have been employed also. Next slide. So how do we endometriosis affect fertility? And there's a tremendous amount of disagreement about that. Certainly if there's scar tissue, because endometriosis is an inflammatory process, but small implants may not cause scarring to occur. Again, higher concentrations of certain inflammatory cystokines in the peritoneal cavity may affect the way the fallopian tube carries a fertilized egg. It may impair implantation. And there's some science that points to some of that, but we do not have a good marker for it. There's some studies that show that endometriosis may contribute to poor oocyte quality, that's egg quality, or embryo development. And then again, finally at the end, distorted pelvic anatomy, because the scar tissue may actually physically affect the ability of the tube and the egg to pass the embryo down to the uterus. Next slide, please. Here we have Carissa now. So I'm going to hand over the presentation. So we've done some of the medical part, and then we'll talk again towards the end. Thank you for waiting.
So to turn our attention a little bit to the mental health impacts of endometriosis. So interestingly, there's a very high correlation between mood and anxiety disorders like depression and endometriosis. So depression and anxiety are more prevalent among patients with endometriosis compared to the general population. Previously, that strong association used to be attributed to the chronic pain that is often a part of endometriosis and the way in which that impacts a woman's life. However, new research is suggesting that the association between depression and anxiety and endometriosis cannot be solely attributed to the pain and the impacts of the symptoms of endometriosis, but that actually, most likely, there are kind of underlying processes, kind of in terms of the immune system and inflammatory processes that can contribute to both the development of endometriosis and mental health conditions, in addition to, of course, the often heavy kind of toll that endometriosis can take on a person's quality of life and the additional stressors that it can add, including reproductive challenges. Next slide. So, it's also important just to know kind of more broadly about mental health and infertility. Uh, it's helpful to know that there are actually some medications that can be used during the fertility treatments that can disrupt mood, which makes sense as a lot of hormones are at play. And we know that hormones have an impact on people's mood, but that's something to be aware of. And then in terms of not just kind of strictly the physiological factors, but the psychosocial stressors. So reproductive challenges can often result in a lot of feelings of loss and grief. Sometimes in people's fertility journeys, they have experienced, pregnancy losses. I was telling Dr. Danzer, for example, that I recently started seeing a client who had 2 miscarriages and then was diagnosed with endometriosis and received the surgery, went on to go through IVF and now has a child and is getting ready for her second, hopefully. But even if it's not specifically like a pregnancy loss, just the loss of the fertility journey that you had imagined for yourself, that can come with a lot of grief. It can also really impact, especially for women, their identity and esteem, body image. We're supposed to be able to get pregnant, and it's not always that easy. It can also result in isolation from your support system. So, particularly if it feels like, everybody else around you is getting pregnant or they're moving on to kind of the next stage in their life as a mother, and you're not yet a mother yourself, that can result in a lot of isolation. Going through reproductive challenges can also, of course, put a heavy strain on your relationship and lead to financial stress as well. I think it's also important to note that communities of color have a 2 times higher rate of fertility challenges and are also 2 times less likely to seek mental health services, which I think is so sad. And we know that seeking mental health support, as early in the process as possible, can really help make a difference, not just in terms of managing distress, but also in terms of the outcomes associated with fertility treatments. Next slide. It's also important to highlight some of the resources out there, right? So joining like a support group can make a big difference. There's a ton of support groups out there for women that are going through reproductive challenges, as well as maybe connecting with an individual like myself, a psychologist or therapist, ideally who's perinatal mental health certified or has experience and training working with people going through reproductive challenges. Like I said, it's ideal to start as soon as possible. Um, ideally before any medical interventions, but certainly if you are going through fertility treatments to get that psychological support. I think it's also important to know that mental health issues can arise in both men and women. I feel like often it's women that experience kind of the heavy impacts of going through reproductive challenges because it is so often associated with kind of, femininity or women's identity and esteem and body image. And they're the ones, of course, that are kind of going through the heavy kind of physical tolls associated with things like endometriosis and things like going through the IVF process. But I wanted to note that mental health issues can arise in men too. And I like the idea of bringing men into the fold and encourage couples to get support together. Next slide. So speaking just a little bit more to some of the resources that are available, I want to highlight the National Infertility Awareness Association's Resolve, which is kind of my go-to resource for locating support. They have on their website a directory of support groups, some which are peer-led, others that are led by professionals like myself. We have a group called Hopeful Beginnings, Pathways to Parenthood, that is meant for couples who are going through fertility, some kind of fertility journey. I encourage you to learn more about Resolve at their website, and then also to learn more about myself and the services that we offer at the Heartship website or online at Instagram. Next slide. All right, Dr. Danzer, back over to you.
Thank you. Great presentation. I've talked with patients all the time. We go through their history and their physical and what they've done before, but I always ask them, how's your stress level? Because we treat fertility, you got to have good nutrition and exercise, but how do you manage your stress? And I've always been a great advocate of mindfulness. And everybody seems to say, oh yeah, I was mindful and I used to do that, but I've kind of slipped away. And the stresses, the psychic stresses of fertility is huge for the women and for the partners also. So I'm glad that we have the kind of support that your group can offer. That's very, very important in terms of a better outcome. And there's certainly studies to show that stress management does improve outcome in terms of fertility treatments. So again, patient evaluation, this history review, like I said, I kind of always try to focus on their level of stress and what tools they have to manage the stress. We do physical examination. Usually that's with ultrasound to look at the numbers of follicles. Each follicle in the ovary has one egg. Women are born with 1 million eggs. By the time they're teenagers, most of the eggs have left for a reason we don't understand to about 50,000. And then you begin to use up those eggs into the late 30s and early 40s when these diminished reserve eggs seem to have a stickier genetics or chromosomes. And so it's harder to get pregnant because eggs may fertilize, but they don't grow. And miscarriage rates also begin to increase during that time. So we have the diagnostic testing, and we'll go to the next slide. And again, we're talking about egg reserve, this AMH blood test, and an ultrasound that looks at the egg reserve. Two of the most important tests we have today to really look at the reason for struggling to get pregnant and what sort of treatment is a best option. So you look at age groups with, you see how it trends down from age 26 to 29 to greater than 40. This AMH, which is made by all the thousands of eggs in the ovary. Each egg has a follicle around it, a group of cells like a little ball, and they make anti-Müllerian hormone, and that can be measured. FSH is another test we use also, but AMH in the beginning is very important. And then you look to the right at the ultrasound. So the ovary, the cells like a chocolate chip cookie, it's really about the size of your thumb. And you can see here's a woman that has about 10 resting follicles early in her cycle. So every month, this woman is recruiting 15 to 20 eggs. And out of that group, one will become the dominant follicle. But unfortunately, the other 18 or 19 then regress and are sort of wasted. So what we do with IVS for egg freezing cycles is stimulate the would-be wasted eggs to maturity. You have to have a mature egg to be able to remove it from the ovary and fertilize it or freeze it for later on. Next slide. We look at the lining of the uterus. Here's another test that evaluates the uterine cavity, tells about how to transfer embryos. And here's a woman that has a polyp, which is an overgrowth of normal tissue. Again, for the lining of the uterus, it develops and breaks down every month. Sometimes it overgrows, and a polyp in the uterine cavity can interfere with implantation. So this ultrasound with saline is part of the evaluation. Next. And here's what they call a HSG, hysterosalpingogram, which looks not only at the uterus, it's injecting again like a teaspoon of contrast material to outline the shape of the uterus to look for, again, polyps or fibroids. Some women have a uterine septum, some have other abnormalities of the development of the uterus. And then we watch the contrast material flow out through the fallopian tubes, and you can see the tubes are on either side of the uterus, and we look for what they call spill. So if the contrast material spills out of along the pelvic sidewall, then we know the fallopian tube is open. And actually, pregnancy rates tend to increase a bit for 6 months afterwards. So they think it's like flushing the tubes. So again, the ultrasound and an X-ray are two diagnostic tests. Um, On ultrasound, endometriosis may show up if it is a cystic lesion, forms a cyst, what they call an endometrioma. But small implants of endometriosis or deep implants don't show up on ultrasound or the hysterosalpingogram. Next slide. So, within our culture, the women probably inherit the greatest burden. The problem is with the woman, and it's not. Much of the time, they estimate that 30, maybe 40% of fertility issues may be related to the development of sperm. Semen analysis is kind of the best test we have, and you look at the concentration and how well they swim, and they also look at the shape of the sperm. We know that probably almost 90% of sperm, or you look to the right there, abnormal forms. They're giant heads, double heads. So millions of sperm are made daily, but you look for one normal sperm out of the group, and um, the normal sperm also has to have good motility, so it can swim and find the egg and then burrow through the outer coating. So you can have a great sperm count, but if the motility is not good, it's very difficult to get pregnant. Today, with men with very low sperm counts, even 100 or 1,000 sperm with in vitro fertilization, once you have the egg in the dish with IVF, you actually inject a single sperm into the egg. It's the genetics that's encompassed by the sperm. The sperm is really the envelope for the genetic piece, and that is the one that fertilizes the egg. So intracellular sperm injection at the time of IVF has really been a cure for most low sperm count problems. But again, it's a little more difficult to diagnose. Sperm may look good under the microscope and swim very well. Sometimes the shape is not great, which may be a signal of why they're struggling to get pregnant. Next slide. Intrauterine insemination is one of the techniques that have used along with fertility medication to improve the quality of the ovulation. And at the time of ovulation, we can find that quite easily with ultrasound. So around day 10 or 12, 14, and that's when the egg is matured for, it takes about 2 weeks. Right at the time of ovulation, the partner gives a sperm specimen, which is washed, or what they call a swim up. So the good swimming sperm move up into a layer of this protein gradient, and you take that gradient and spin it down to a few drops. And the few drops of the probably 20% of the sperm that are really the good swimmers can be placed in the center of the uterus. So they're halfway where they need to go to find the egg. And that's helpful for men that have lower counts. If they're really low counts or very low motility, IUIs are not very helpful. But for moderately low sperm counts, the intrauterine insemination is really very helpful. Next slide. So here's kind of a graph of what we do with IVF, and this is the egg retrieval timeline. So we do a basal ultrasound to look and see how many follicles we have. Some women have 6 or 8 follicles, some have 26. But it takes about 12 days to mature an egg, and they use injections of follicle stimulating hormone. It's been available for 40 years, and it's estimated in a recent study that came out of Europe that they estimate there's more than 10 million women that have become pregnant through in vitro fertilization through this European group that they were analyzing. So it's a very tried and true technology. We know that injections of follicle stimulating hormone, it's the natural molecule. It does nothing in the body other than stimulate the maturity of would-be wasted eggs. Towards the end, when you have 10 eggs, the estrogen is 10 times would be otherwise. So a lot of bloating. Some women say, I feel great, the best I've ever felt. I talked to a woman today. Most don't really feel too off emotionally with it, but almost everybody complains of the bloating from the very high estrogen levels, because each follicle makes estrogen to mature that egg. So about day 14 of the injections have been stopped, and then the eggs are retrieved by ultrasound with a very light anesthesia. Takes about 15 to 20 minutes on average, and most women are able to take Tylenol and leave within an hour, hour and a half. So it's a very safe procedure. Bleeding infection is really very unusual. But again, it opens the door for women that have endometriosis, that you have a group of eggs you're taken from the ovary, you fertilize in the dish, you grow the embryo, and you're going to transfer to the uterus. So if there's scar tissue within the pelvic cavity preventing the tube and functioning, so the tube can't get a hold of the embryo or travel properly or implant, in vitro fertilization has been a very great treatment in that situation. Good, next slide. So again, this is just kind of a diagrammatic of what it is of an ultrasound. You see a very thin needle that goes, it looks like a long distance. The ovary sits right next to the vaginal wall, which is just like when you draw blood, the skin is very thin there, the needle goes through, and you can see on this bottom slide how that needle just goes within a quarter of an inch into the first follicle. The fluid is aspirated, and the fluid is the microscopic egg. So the fluid is transferred right into the next room to the embryologist, and the embryologist then takes the egg from the fluid. So this is the actual IVF process. Next slide. So here's embryo development, and you can see the little video to the right. It shows an embryo, and it actually shows them taking some cells from the embryo for genetic testing. But you have to grow the embryo for 5 or 6 days to get to about 100 cells to when you can take 3 or 4 cells for genetic testing. And taking the cells from the embryo rarely damages the embryo itself. And you can see those cells are kind of separating off into the tube, and they're going to send that to the genetics laboratory for analysis, which takes about a week. But it's a safe procedure. And again, at the 100 cell stage, biopsying the embryo does not damage the embryo. And here you see sperm and egg have gotten together in the very beginning. You get a 2, 4, 8 cells, 12 cells, 20 cells about day 4. And then finally on day 5 or day 6, you'll see that kind of blossoming of the embryo to what they call the blastocyst, about 100 cells. And at that point, you could do the biopsy and freeze that embryo. And the freezing technology is very good. Thawing an embryo like that is successful 98% of the time. So we're lucky in that way that once you get an embryo, you can genetically test it. Genetically tested embryos transferred to the uterus. Pregnancy rates are close to 65, 70, maybe 75% for young women under 35. And again, there may be some impact of endometriosis. So there's a lot of emphasis now trying to identify women that may have endometriosis to get some treatment before we transfer the embryo. So here we are at the end, over 20,000 babies, millions of memories from SCRC. Next slide, or is that our last slide? So we can, I think we're ready for some questions. There's always great questions. And I know that's why you visited the webinar today, is you're thinking about fertility options or endometriosis. So we're happy to try and answer those questions as well as we can. I see a first question. They're asking, is necessary to suppress probably endometriosis transfer of surgery complicate? I don't know if I understand that question. In the context where we have known endometriosis either by symptoms or laparoscopy or maybe a marker with CA-125. Generally, you would suppress with Depolupron, which for about 2 months, because the only thing that makes endometriosis grow is estrogen. So if you suppress the estrogen, it can enhance the pregnancy rates and the implantation rates when you transfer a genetically normal embryo. Guess we have a second question. At my current clinic, the RA insists saying that your endometriosis will go away when you are pregnant. And endo doesn't affect fertility. Well, it can, but again, it's difficult to identify the subgroup that has the endo. Small amounts of endo, many women have, and they get pregnant in spite of it. There is a test called Receptiva. It's relatively new, but it's relatively controversial because half the patients that have the test, it takes a biopsy of the uterus to get tissue and test, but half the patients are positive. So if you end up with half of the people tested are positive, why not just do the treatment for everyone? So there's a lot of controversy about how many patients you treat to get benefit from that. You don't want to overtreat women with Depolupron or surgery. The thought was when we have endometriosis to get suppressed during pregnancy because there's a lot of estrogen and progesterone, and women that have endo, they get pregnant and their pregnancies may be easier to achieve after they've had a full-term pregnancy. Chris, you probably deal with women that have had what they call secondary infertility. They got pregnant relatively easy. They might have miscarried or had a full-term delivery, and then they're struggling to get pregnant. I know some of that is age-related, but that's one of the more difficult groups we have to work with.
Yes, absolutely. Um, I've actually had a client struggling with secondary infertility who actually she went through like 6 IUIs, and then she took some time off from work, went on disability. We worked together on managing her stress and anxiety, and she shared with me earlier this week that she's unexpectedly pregnant. Um, so yeah, a lot of happy stories out there, and I'm relieved to hear that having a successful kind of like pregnancy when you've had endometriosis, if I'm getting this right, Dr. Danzer, kind of increases your chances for pregnancies after the fact. I have a few clients right now who I mentioned one earlier who had endometriosis and had the surgery and had a baby is going to try to get pregnant again, and another client here who didn't have a diagnosis of endometriosis, went through IVF, had a baby, and then is trying again now. And on the ultrasound, was told by her physician that she is showing signs on the ultrasound now that suggest that she might have endometriosis, which was not diagnosed or detected beforehand. Which, just to add about the mental health impacts of that can create a real hardship, right? When women don't know what's wrong. You spoke earlier to silent endometriosis, and it seems like it can take women years to be diagnosed, or they might even go undiagnosed. But I'm happy to hear that with treatment, people can get pregnant, and that it sounds like it might be easier, to go on to have future pregnancies.
I think we know that endometriosis is a slowly progressive process. Um, and again, a woman may have able to get pregnant earlier on, but then after a successful pregnancy, the endometriosis process continues on and may be the cause for their secondary infertility. Um, Secondary infertility is a struggle for many. Is it a reboot of their ovulation? They come back, their periods are normal. They got pregnant before with that. But is the reboot exactly the same as it was before when she got pregnant? Has silent endometriosis then become a clinically relevant endometriosis? And then again, what's the stress factor when you got pregnant? Now you can't. And then, of course, you got a kid at home and you got trying to balance that with work. And I'm sure you encountered that too. The juggle today with the young family, the young mother trying to manage a family and a job at the same time.
Yes, absolutely. Um, and not that this is necessary in all cases, but I've worked with a number of women who, because work can be such a stressor,
Yeah.
who have gone on leaves of absence from work, and because the IVF process can be so taxing too. To take time away from work and to, or not, but to be working with a therapist on managing stress and using kind of some of those mindfulness based interventions. I actually specialize, in addition to perinatal mental health, in acceptance and commitment therapy, which I wrote a book on, which is a mindfulness and acceptance based behavioral therapy. So I work a lot with women on learning how to better manage their stress and anxiety, which includes often letting go of things outside of our control. And it seems, that obviously when you're wanting to have a baby, you do as much as you can to kind of control that process, and you want a particular outcome, and yet um, we can't always exactly make that happen on the timeline or in the ways that we want. So I work a lot with often very high achieving, ambitious, career driven women on trying to let go of control, trying to practice acceptance, trying to de-stress and just focus on their health, or even sometimes just focusing on their happiness, as they're taking actions and steps towards, doing what they can to try to get pregnant or try to get pregnant a second time around.
I think there's certainly a much greater awareness of the psychological impact of stress and on one's fertility and one's general health. And we talk about people to eat well, exercise. I think is a stress reducer for many, but that's not all that's out there. I certainly work with a therapist to identify those kinds of issues that created more of a stress when they're working for fertility, stress on the relationship, and other stress at work. So stress does affect our physiology and also our mental physiology. So I see Diana here has one. Thank you for. I'm looking to be an egg donor, and I am self-diagnosing. I have endo, so let the donor agency know I have suspicion that I have endometriosis. Yeah, I think that would be important. I think to uh, either work with your endocrinologist or someone to uh, attempt to identify uh, indeed you have silent endometriosis or you're actually having the symptoms would be a diagnosis such. Um, would the stimulation process of donating eggs uh, sort of flare up the endometriosis? We know that endometriosis is um, created by spikes in estrogen at ovulation. Um, I think over the years, I've seen a few patients with endo that probably were more aware of the pain and uh, that is associated with endo after a egg um, stimulating process. You don't see it very often. You'd think you'd see it more often. That endo, if it was there, would sort of be magnified by all that estrogen stimulation. But it has some effect, but it's difficult for us to diagnose that. Trying to scroll down here. Sorry, I'm getting behind. Um, And someone's asking if you have a laparoscopy, an excision of endometriosis within a year, is it necessary to suppress with Lupron? I think it depends on how well the surgery treated the endometriosis. Uh, Again, it's they may have small little what they call powder burns or small cysts, which can be lasered, but there may be endometriosis deep under the what they call the peritoneal surface, and that can be treated with Lupron. So if the physician says, "Well, I think I got most of the endometriosis that I can see, but I'm suspicious on MRI there may be deep endo," well, then certainly uh, Lupron is used if they think that they incompletely resected the endometriosis. And how many successful cases have you had where the patient with endometriosis was able to achieve a pregnancy? Again, I think that is age related. We know that The group under age 35 is different than the group over 35 because of the genetic issues. And again, it depends on the degree of endometriosis. The stage 4, where there's actually scar tissue, that could be very difficult to achieve a pregnancy. But there are many successful cases of endo. It is very treatable, yes. It says the effects of IVF on endometriosis after injecting all those hormones will cause a flare-up. So we hadn't talked about that. It doesn't seem to happen very often. I've kind of seen a few cases over the years where you could visibly see what we thought was the progression of endo. We often use a marker called CA125, and you do see that marker increase occasionally. It doesn't happen very often, but CA125 usually drops down, and we use it a marker when they have hormonal treatment. So by giving depolupron and reducing the estrogen, you can watch the CA125 decrease to a normal level and then initiate, transfer of embryos or other treatments. A lot of medical things here. Had one miscarriage and had a polypectomy and a DNC. That's to remove an overgrowth of tissue. That's a polyp in the uterine cavity. Can they come back? Usually not within 6 months to a year. Polyps, they say, have to be about close to a centimeter to cause difficulty getting pregnant. We always do a test with that water test called a sonohistogram to look for polyps before we transfer embryos into the uterus, because you don't want the embryo implanting on a polyp because it does not have a good blood supply. So generally, you do treat polyps before you attempt pregnancy. And then Nancy here. So I was recently diagnosed with large pituitary gland. Neurosurgeons thinks I don't need surgery now, which is good. Would this be an issue? I want to go ahead with egg freezing. I think you can go ahead with egg freezing as long as there's what they call a microadenoma. And as long as you're having regular cycles and ovulating, I think you can certainly go ahead with an egg freeze cycle. They'll certainly look at your prolactin to make sure that that's not increased in your TSH. Any opinion on the Time magazine article about the inaccuracy of PGTA? Biopsy is either on the outer shell, and the bad cells are pushing out to the outer cells. One of the theories. So again, we talked about, you saw that little video of how they were taking cells, placental cells, what they call trophoblasts, or what they send off for testing. The correlation with what you see with what they call the inner cell mass, the actual fetal cells, I think is quite good. The initial development of the genetic testing where they biopsied both the outer cells and the inner cells, the correlation was 90-some%. Again, there's been some, I want to say, research study recently, a group that thought that the concordance was not as strong as initially thought to be. I think the bottom line is that with genetically balanced embryos, with the technology that we have today, 23 chromosome pairs, one from the man and one from the woman, the pregnancy rates are in that 65 to 70% range, possibly 75% when the woman is under 35. So it's, I think the PGTA is not perfect. There's some undercalls and some overcalls, but that's just the limit of the technology. But I think many have kind of shied away from biopsying the intracell mass because those are the fetal tissue. So that's a controversy right now, and I think we're going to have to wait for a while to get more studies to really answer the question about that. It says, when is it better just toss in the towel and use a surrogate if one has endo and frozen embryos available? I think, again, it depends on the degree of the endometriosis, how long you've been trying to get pregnant. Certainly, using a surrogate is an involved process and expensive. But it also depends on the history. If you've been unsuccessful with embryo transfers, with good quality embryos, then there is an argument to have a discussion about using a surrogate. And then another question, any suggestions for women over 40 with endometriosis to improve egg quality? I wish we had something. Again, age factor is huge in fertility. We know that pregnancy rates and the percentage of normally tested embryos genetically are directly related to the woman's age. But there are some women that have a very good reserve at 40, and you get 6 or 7 embryos to test. And then there are other women at 40 that get maybe 2 embryos to test. And again, the differences in the pregnancy rates are huge because you have more embryos to look for that, what they call golden egg that has the genetically balanced embryo. So I don't know if there's any dietary issues. People always ask about diet. CoQ10 has been used for years. I think that is kind of soft and how well that improves egg quality. But anything that improves your general health, talk to people about good nutrition, a good exercise level, 30 or 40 minutes a day of a walk, has tremendous health benefits, not only for fertility, but for just your life in general. Because many of us have that sedentary lifestyle. We sit down to work because working on the computers. I think it's different than the last generation that got up and was moving. Um, Maybe Carissa has some thoughts about how the society has changed in terms of their physical and mental health with computers, how we spend our life
Yeah.
on the screen.
Yeah, I'd like to speak to that a little bit too. Thank you for that opportunity. But in general, right? Like you're saying, what's good for your health is good for your fertility. What's good for your health, physically speaking, is also good for your mental health. And you mentioned kind of like diet and exercise. I would add to that things like sleep, things like abstaining from our limiting substances, and also things like social support. Sometimes people forget about social support as a way of managing stress, but it absolutely is, and that's one of the reasons that connecting with like a peer or professionally led support group through Resolve or working with an individual therapist can be impactful, is because social support matters. And in addition to that, kind of again, like this letting go of control, sometimes people put so much stress and pressure on themselves that it actually kind of just increases their stress. And so sometimes what I talk to women about that are undergoing kind of reproductive challenges is like, what makes you happy? And doing the things that make you happy and actually kind of like letting go and having fun, which is another way of kind of just getting at reducing stress. Yeah.
Stress is, and it's hard to quantitate stress. People ask, how do you quantitate that? I mean, certainly you're a better evaluator of that than us physicians in many ways. Uh, but to have a plan to manage the stress going through fertility it's a stressful process. Um, There was the last question here. I was recently diagnosed with stage 4 endometriosis, and that staging is one that has scar tissue in the pelvis. And again, in that situation, the fallopian tube may be scarred and pulled away from the ovary so that the egg may not even be able to get to the tube or carry the uh, fertilized egg or embryo. Um, can egg freezing still be an option? Absolutely. Um, Again, there's some issues about endometriosis and egg quality or embryo quality. It's not huge. Most women with endometriosis can get good quality embryos, and particularly if they're young. So egg freezing, if you're uh, in your early to mid 30s, that's a time where you want to freeze eggs because they're the best chance when they're genetically balanced. And then uh, frozen eggs are good for 10 years. Um, so egg freezing is an option. Yeah, I don't think that's a major issue. I think everybody would encourage that, given the stage 4 endometriosis. to freeze the eggs as soon as you can, because they're genetically going to be better than they will be in 5 or 10 years from now. Someone was talking, what are your thoughts on ovarian regeneration, rejuvenation, a waste of money? I don't think there's any good studies uh, on injecting PRP into the ovary. I think there's a lot of people that are looking to what the process is. How is it that the ovary recruits a given group of follicles? Why do some people lose them more quickly than others? Can we rejuvenate or mobilize some that are in the outer cortex? And all of this work is really experimental at this point in time. And again, it is costly. I don't recommend it because I'm kind of tend to be more of a scientist and say until we have good information and a good study to say that it's worthwhile, I think you ought to focus on perhaps again, regeneration is for women that have very low reserve or they're in their mid-40s. I think really have to look at donor egg. I know that's a huge wall to climb over psychologically, but you can spend so much time and energy and pain in your your life trying to get pregnant when you're in the mid to late 40s, when we just rarely see pregnancies. Maybe Carissa can talk to that a bit too. And at what point in time do you let go?
Yeah, it's one of those things that I think is very deeply personal, and that it makes sense to be working with an individual therapist, to kind of talk through your options. Um, but it's a very deeply kind of personal decision. As you mentioned, it's a big kind of psychological hurdle to jump through, in kind of, considering to use an egg donor or even, using a surrogate or other kinds of things that people need to consider, even if they want to continue their IVF journey. Um, but I definitely think that working with an individual therapist to help process like the loss and the grief, is going to be really important for that, and navigating your options and really making choices that are right for you when they're right for you.
Yeah, it's important to have someone like yourself help to um, get closure uh, medically, but psychologically, you have to get closure before you can move on, and that is not an easy process for almost everyone. Here's a good question here. I had my AMH done when I was 39 years old, and it was 2.27. So anything over 2 is tells you that there's a reasonable egg reserve. Now I'm 43. I know my egg quality changes about every 6 months, but do we still have a good chance to getting pregnant naturally? Um, so we know on average, 1 out of 4 eggs at age 40 is genetically good. At 43, it could be 1 in 6 or 8 or 10. You may have 1 or 2 genetically good eggs per year. And it may come next month when you're trying, but the next good egg may be 8 months away, and then you're 44, and then it's 1 in 12 or 13 eggs. So everyone is different. It sounds like you have a pretty good reserve. But I think if you're thinking about starting a family, you want to have an evaluation and see what your egg reserve is, and develop a course of therapy. Stimulation of the ovary with oral or injectable medication or IVF is something that certainly would give you the best chance of having your family. And then somebody says, thanks. Do you think uh, endo is hereditary? Yes, it does run in families, absolutely. And everything about us is genetic. But yes, you see women and we always ask the question, is there endo in your family? And if you have a sister or mother that has endo, you're more likely to have it. And again, that can affect the way we develop a treatment plan for someone. Another question is the transfer with stage 4 endo a no-go, rather than just to get a surrogate? Again, there are women with stage 4 endo that have elevated markers like a CA-125, and once it's treated surgically or hormonally, they may be an option to transfer an embryo. It depends on the quality of embryos that you have and the number. If you have 3 or 4 genetically tested embryos, you might say, well, let's transfer one for me. But if it's unsuccessful, then perhaps to move to a surrogate. But I think that depends on the number of good quality embryos. So someone is asking if we're going to have a session on anovulation or where you don't ovulate. And that's a good question. And that's we can put that together. I'd be happy to do a session on women who don't ovulate. And certainly that could play into, Chris has probably seen patients over the years that had irregular ovulation, and you were able to improve the quality of her ovulation and bring it back.
Yes, I actually had a client who, without a diagnosis or anything, thought that she was going to have a lot of trouble getting pregnant because she had very irregular cycles, and she was partnered with a woman, which necessitated that they use some kind of, reproductive technology, and got pregnant right away, and sought therapy because she wasn't very confident in her body's ability to kind of like be pregnant given her very irregular cycles. So there's a lot of really interesting stuff that can show up with fertility and people's, pregnancy journeys and psychological health. So we're here to help support you, medically and psychologically. And I think that can make a big difference when you combine the two.
I think we're out of our time now. It's right at 5 o'clock. It was it was an honor to work with you, Carissa. That was, get your insights in how all of this plays with endometriosis and fertility in general, and to be available for women couples that need help. So thank you very much.
Yeah, thank you so much, Dr. Danzer, for having me. I was really excited to do this and love that you guys are, highlighting the mental health piece, because I can't tell you how many women I'm working with kind of after the fact, and I think that people really benefit from getting that support early on, again, as kind of early as possible. So I'm so happy that you guys, are doing this webinar and kind of drawing attention to the mental health impacts of things like endometriosis that can take so long to get diagnosed and have such a toll on people's lives and negatively impact their ability to get pregnant. And women so need kind of that mental health support as they're navigating reproductive challenges. So thank you so much for having me. It was a
Well,
pleasure.
we should do another one soon. Absolutely.
Yeah, absolutely. I would love that.
And thank you everyone for attending, and hopefully we were helpful in your journey to build your families. Thank you.